Welcome to the Global Health Diplomats, brought to you by a Shot in the Arm podcast. And it's me, Ben Plumley, and I'm here with my regular guest and commentator and co-host, Professor Ambassador Eric Goosby. Well, Eric, can I just say that I am really disappointed that you didn't show enough respect to this podcast by not wearing a suit.
Well, I immediately felt transgressed, so thank you for bringing that up. But next time, I promise you I'll have a jacket on.
Well, you can see from me as well.
Yep.
So in this podcast episode, we thought we would just, now the dust is beginning to settle, see where things are, and then as it relates to the executive orders, the litigation against those, but then really spend the bulk of the podcast looking at what happens now. Where do we go to from this point onwards? And really, you know, global health is dead. Long live global health. So what are your top line feelings now you've had a chance to have a few weeks to reflect on?
Yes, well, thanks, Ben. It's been a period of feeling transgressed and lost to being able to find a conversation that you could lock onto and carry forward. I think that the Trump administration has found it to their advantage to make proclamations that set a ball rolling down a given trajectory in a given agency area, and then kind of letting it hit and seeing what happens is not the responsibility clearly defined in that effort of which pins fell over, which pins stayed up, and what were the overall outcome from the carnage that occurred. That discussion is not happening before, during, or after yet. And it's our hope that this week, next week, out of necessity, the Trump administration will have to engage with leadership around program on the specifics. Once that starts, we'll begin to understand what we're left with in the way of the footprint that was before the Trump administration, and then allow us to formulate what we'll put together for the post-Trump vision, understand what their priorities are, understand what they feel should continue, can continue, and most importantly, what should stop. If there indeed is a stoppage agenda up, that is the critical piece to let those in the medical delivery system who are responsible to ensure the outcomes that we're after are achieved, understand that, and that we don't dismantle those delicate pieces of the orchestration.
So listening to you, Eric, I'm still sensing a bit that you are still holding out some hope that something can be salvaged from this. Am I reading you right? Or do you think that this is essentially over?
Yeah. No, you're reading me right. It would be premature to assume that it's over. We, in many ways, may have an opportunity to pivot the current commitment and program footprint into a better version of what governance should look like in the countries that we partner with. I would say that the models that we use for global health delivery that come into a country and define unmet need and prioritize that unmet need in a distant process that's happening 6 or 7, 10,000 miles away from where the actual program is run, dilutes the ability to understand the appropriateness of that prioritization. The allocation decision once made then can't speak to the allocators if it was the wrong decision, and a correction is never introduced back into the system for the second half of the first year or for year 2. And in programs that self-correct, and PEPFAR was one of these types of programs, the data collection was focused on giving the program management an understanding of where they were at any given point in reaching the outcome of not seroconverting, keeping someone undetectable, CD4 going and continuing to rise type metrics those really are require a clarity of function, but every single element to achieve those outcomes we understand and know how to do. So to dismantle something really is not as tragic as it could be, because we are smart enough from the work that went into implementing and the implementation science that helped define it, smart enough to reproduce it in one country after another, in one province after another, and that's what we've done.
So, okay, maybe another way of looking at it, and just playing devil's advocate, is, okay, this is the day after that State of the Union, and I'm using air quotes because it wasn't a formal State of the Union. And this morning, the Supreme Court affirmed decision of a lower court to unfreeze, I think, $2 billion of USAID funding. Great news, but so many USAID staff are no longer working that the concern is that there's going to be no way we have the headcount to manage the restarting of these programs. Clinics and facilities in countries have closed, remain closed, and as it relates particularly to PEPFAR, we've had a load of termination letters going out to folks, everyone from EGPATH to Chemonics to UNAIDS, and only a few of those are being unterminated, as it were. So given the jarring, sudden stop, putting the brakes on this, how is it possible to, from the donor perspective to kick off with, how is it possible to get things restarted again?
Yeah. Well, I think you're correct in presenting it as a problem that could be a game stopper, and it could be. But I've run too many programs for too many years to think that closing a program for 2 weeks shuts it down. The problem will be if they sell and get rid of the HR that reflects that program in nurses, doctors, procurement distribution people, lab people. Those are the elements that make up that continuum of care and services that completes the commitment to the patient that we're going to care for them and get the right pill in the right mouth in the right time. And I think that can all be restarted. The problem, as I say, is if people go off and take other jobs. As we wait another week or another week, that job exit is real. Right now, we're in a little window where most people haven't figured that out yet, but the doctors and the nurses have options that they will take, and they will take them as a function of the best offers are going to come early, and let me take advantage of that. And I worry that that will happen. That hasn't happened yet. If it happens, we have a different problem, but a problem that we can solve nevertheless. What I'm talking about is the inertia in a system that wants to shut down. That is what we're really seeing. Are we really seeing?
Well, that's it, isn't it?
It is. Are we seeing an agenda that is really trying to play out the closure of USAID as it is now, not a function of DEI or too much T in the LGBTQ activity, is not the reasons for any of this work to be closed off and shut down. And I don't believe that that the in-country reflection of this continuum of care did that yet. We need to now police that part of it. But I can tell you that the fear that the Trump administration has put in principal investigators, academic medical centers that take these resources and translate them into program is high. They are fearful that if they criticize or look like they're not cooperative, that they will be punished by a defunding decision that comes in with them, not this year necessarily, but in future years. And that threat is criminal, that it is being put forward without any clarification or let me explain what we're doing here coming forward as well. The silence allows all of this to for people on the receiving end of grants to be thinking that there's a decision made here to stop this program. And for a program that has been the essential piece to stop a person from dying to go away raises an abandonment of care question that the United States programs and the Global Fund programs, through a third of which is funded by U.S. taxpayer dollars, that our position with these programs is one of we cannot leave the program so that the services suddenly stop and are no longer available to the people that for 23 years we have been committed to. That abandonment of care in a medical legal sense is something that the United States, when we started these programs and we went from 1.7 to 5 million people on antiretrovirals, President Obama and Secretary Clinton were very clear, and under my questioning, if we get in a war with these countries, are we going to continue these services or withdraw them? And the agreement was that we would not ever withdraw these life-saving, sustaining interventions, that an abandonment of care problem is there and we would have to transfer the care before we left. And that still stands in my mind right now. So that card has not been played.
So that's interesting, because you have a level of pragmatic optimism that I confess I don't feel and I don't see. Mm-hmm. And while President Obama and Secretary of State Clinton made these commitments, I don't see President Trump, and this perhaps is one of the greatest shames, Secretary Rubio making or being in a worldview that would make the same commitments. One of the things that I think is interesting in this moment is that, in a sense, our partner countries have, this is not new to them. Contracts, grants have always been terminated, sometimes with no notice at all, but there have always been subsequent things that people can apply to and be able to redirect, even if it means changing their priorities to match the donor priorities, which, as you know, it's not something that I think is a good idea, but there we are. What I'm hearing from folks running programs in countries is that actually the other way that we've been here before is through COVID. And in fact, what we're seeing now is COVID too. First time round, countries in Africa went right to the bottom of the queue when it came to access to commodities like oxygen and, of course, like the vaccines, like the surveillance and monitoring and evaluation of what was happening. And they had to make do with what they've got. What they've got had largely been the aged response. And so the HIV movement was very effectively pivoted to address the COVID needs of countries. And I'm beginning to hear folks in countries saying, well, look, we're just going to have to do this again. We're going to have to ask some tough questions about what is in scope and what is out of scope. But sooner or later, we were going to have to be running things ourselves. It would have been nice to have a little bit more runway. But we've got to embrace this moment.
That would be a really positive outcome to an unfortunate sequence of events. If this resulted in countries realizing that it is on them, as was presented to them with COVID, you are absolutely right. What they were told with COVID is you are on your own. Even though we gave a drumbeat of we're responding with you, the actual fact of the matter is each country was on their own. The African countries got that message and have taken early preliminary steps to make sure that a manufacturing capability is possible in sub-Saharan, and they see maybe with more confidence than it deserves that having a manufacturing capability ensures that you get the product of that manufacturing. It definitely makes it more likely, but it doesn't ensure it, and we need to make sure both happen. But to have manufacturing in country is a critical big step, and we are thrilled that it can be realized. Unfortunately, having to back into it with the COVID abandonment is really what occurred there. But it's good that countries realized that it was on them and that no one was coming for the rescue. That mindset we need to hold and use to our advantage to work with our partner countries to expand their capability to do it themselves. And I mean truly do it themselves with their own relationships, with more expertise that they access and source in country first. And now with 20 years of HIV TB work having come to them, there's a lot of expertise at all levels in the delivery system that weren't there a decade ago, that we must take advantage now to anchor them, find their funding lines so they're preserved to be there for the future burden of disease. And that would be a wonderful outcome to this. The governance of a multilateral orchestration, what part of that is not bilateral? We need to have real discussions about what part do we need to still, as a global community, have the ability to identify resources that are outside of country that can come in an emergency or for a prescribed period of time with a treaty-level type agreement, move together with resource movement going into country to be and fund the response that they need to mount. But it's their response. They're responsible for the outcomes. We can't disassociate the outcome of the investment from the people who make that allocation decision. So to me, that governance issue we talked about is still critical.
So a slight detraction here. Eric, we are just like the global AIDS response, dealing with self-sufficiency, taking advantage of what you and I have, and taking advantage of new technology. If you're watching us, you will see that Eric and I have really interesting little microphones. And what I'm going to say to you, Eric, is don't touch your... Also...
As I finger it all over.
Yeah. Come a little closer. Yeah. If you're watching us on video, we're supposed to be giving ourselves a little bit of space. Yeah, that's better.
Okay.
That's better. We're good. Okay, so what happens next? You think there is a role for US-based global health folk. I guess we're not in the driver's seat anymore. I think that's a good thing, but do you think any others first up can fill the gap? And I'm conscious as well that we've had this preliminary hope that just maybe the Europeans might step in a little bit more. Anyone who knows European funding, overseas development funding, will know that's a challenge. And of course, last week, the United Kingdom indicated that in order to meet increasing defense needs, it would pay for its military from savings that it got from cuts from overseas development aid. And I'm sure we're going to see a lot more of that. So are there other gaps? Are there stakeholders who could potentially fill the gaps that the Trump administration either deliberately or accidentally is going to let fall through the cracks?
No obvious actors that have historically been in this space are available. The old actors don't have the bandwidth or the resources to cover the full complement that the U.S. represented, nor should they in the kind of larger preservation and sustainability issues of the programs. To have just one large funder was never smart. And the diversification of a funding portfolio with other funders strengthens the funding, the ability for the funding to remain. But I think that the need to go outside is precipitated by the Trump administration's decision to deprioritize this as an item. The ability to reprioritize it is still on the plate, and the ability to have other players, as you're saying, fill those gaps. I think European, EU, kind of / NATO type country engagement will occur as is available, but as you've said, is extremely limited. From the 2008 recession, most of them never came back.
Yeah.
The UK completely freaked out and changed how they do everything, got rid of DFID and put it all in one shop. And that diminished their footprint and diminished their impact. And they would be the first to admit that. The German French does not have the bandwidth to even come to the table to maybe take up the mantle. So whatever the European countries can do will be appreciated and is needed, but the absence of the United States cannot be taken as a given. We understand that there's a priority that's been made, but what does that exactly mean in terms of the investment? And that discussion needs to happen with Trump administration leadership. It is unethical not to have it, and because of the threat of being charged with a withdrawal of care charge medically, we need to make this a transfer of care. We're smart enough and capable enough to do that, and we just need to hold the investment secure so that does not unravel before it can occur.
But a month into this, there's been no indication, has there, from the administration that they want to have that conversation. And what are you doing? You're holding their feet to the fire and saying, you know, you made this decision, you threw all the toys out of the sandpit, you've got to come back and present to the world your plans for the future. And then let's have a debate about it.
That is what we're still holding them to. They have never done that in any other sector. So we've noticed that. We're not stupid, but that is the expectation. In global health and in the medical profession, that kind of expectation is just being professional and should be part of the routine, and that's still what we're holding them to. So if they transgress that, that will be unfortunate, but we'll have to take it when they do it.
So if we can sort of look into our crystal balls a little bit, take the worst case scenario first, that we have to take the Trump administration both seriously and literally. That's it, done. What are the priorities that you think country programs really need to focus on? And I've got to say, I'm setting you up for this because you and I had a conversation about this last week as we prepared for this, around procurement and distribution, around surveillance and monitoring, and about the sort of broad non-health response that HIV requires. Have I captured those priorities right?
Yes. For a country to assume the responsibility of responding to the burden of the disease that's in front of them, HIV, TB, let's say in this instance, malaria, COVID, a new pandemic, any of them could be substituted for it. But your ability to see the disease when it appears, to be able to accurately demonstrate how it's moving through the population, started here and then where did it go, and your ability to bring that high-risk group into a relationship with the delivery system that allows them to be identified, tested, and once tested, assessed for presence of disease, have the disease treated, and if for HIV, opportunistic infections, go on to treating the underlying viral disease. That progression requires a delivery system that can take a person, test them, bring them back into the care, get the results, initiate a treatment, and follow them over time. That ongoing relationship that's required for the rest of their life requires a robust delivery system that has the resources to stay in front of the patient, and when the patient does not come back, is lost to follow-up, has the resources to find them. Once or twice for sure. Ideally 3 times. And that's a delivery system that has done what it can to keep that person in care and have them benefit from the science we know.
So then, getting really into the weeds here, the procurement and distribution challenge. One of the aspects of the global health support, global communities support to countries through the Global Fund and through PEPFAR has been the use, essentially, I'm maybe oversimplifying, but the use of northern procurement and distribution mechanisms and contractors. Those have gone away. And do you see the potential for organic local organizations, whether nonprofits or companies coming up to fill those gaps? Because that's one of the things that I think countries are certainly exploring.
Yes, USAID put a huge amount of its effort into expanding capability of partners in these partner countries in the building of the delivery system for HITB and malaria. It's the same procurement distribution system needed for any commodity in the lab or in the pharmacy that needs to go from where it's made to where it's going to be dispensed. And the integrity of that delivery system determines whether or not the person benefits from the science. If it doesn't reach the exchange point, they don't get it, and the dose is missed, and the virus replicates, goes up to higher numbers in the blood, and the person becomes infective. And that rotating door of viral load down going up has been something that has plagued us with HIV in every population we've dealt with, from people in high-risk communities and developed settings to people that just are socioeconomically marginalized in developing settings. There are always groups of people that are consistently at a higher risk for transmission than in other settings, and the system needs to figure out who they are, target them and get them, and keep them in the delivery system, or they become the ongoing seroconversion motor for PMTCT and pediatric AIDS. And we've proven this in countries already. By doing that, you eliminate the pediatric component of your outbreak. By stopping that. So the long actings are a whole nother contribution.
I want to come on to long acting in a minute, but let's then deal with surveillance and monitoring. Because in theory, we have at our fingertips a really organic, well-developed set of capacities and expertise and staff that have been trained up in countries to be able to monitor how an epidemic is going. Some countries might argue that while the capacity is in theory there, in practice it hasn't been put to the test because, again, looking at the Global Fund and PEPFAR, the requirements for monitoring and evaluation for surveillance have really been, I hope you'll excuse me for saying this, but sort of more top-down than down-up.
And they have been, and it's a criticism that should be owned. If you don't know it's there, if you don't count it, you don't know it's there, is where I should say that. And that's really true in my whole career. That has been emphasized over and over again. I can't talk to you about anything if I don't have any numbers to tell you what it is. I also know that for those listening to those numbers, it often doesn't matter what those numbers are to those people, but that's a different problem. And it's a different argument if you don't have those numbers. So a credible, scientifically based argument that you need to act country or government X, Y, or Z is usually based in a number analysis of how many people are burdened by your disease, how many people could be, and with these interventions, how do we change that trajectory and diminish the number impacted? And we're doing things that drop the number of infected and take those already infected, make them uninfected so they can't infect others, and stop progression in them. So they're essentially cured. So there's nothing bad about getting and being locked into care. The surveillance system enables you to do that. And it's an investment that people don't always understand its connection to the outcome, but it's literal and direct.
So you mentioned long acting. And when we were having conversations at the end of last year, thinking about the post-2030 long-term response to HIV agenda, both of us were very excited about long-acting, and particularly a product that is beginning to be rolled out, lenacapavir, that is up to, 2 shots a year, 2 injections a year, both for treatment and for prevention. Okay, so how realistic in this environment is it for us to think that this kind of innovation can still be prioritized?
So in terms of burden on a delivery system, a person who requires one shot twice a year is a whole different animal than somebody who has to come in every 3 months, get a drug prescription refilled, get blood tested, and a physical exam. The burden that it used to be when people would progress with their HIV and get opportunistic infections was several times that, and that's when the hospitals were full of HIV positive people, 4 people in a bed era. That all stops if we know how the virus is moving through the population, not just the individual, which we stop with the antiretrovirals, but the antiretrovirals also stop the movement of the virus through the population, first by blunting the high-risk group transmission, but then everybody, once undetectable, becomes the norm.
Because what we might find ourselves seeing in terms of pushback is, the investments of a Ministry of Health around implementing a long-acting strategy, notwithstanding the medium-term cost benefits that you're describing. The upfront costs in setting that up might be a bit overwhelming at the moment, and we might find ourselves being asked, well, can't you go back to how you did things before PrEP? Just put a condom on it. Just cross your legs and say no, and if you can't, put a condom on it.
There'll be those pressures. And, on a government's perspective, cost is a real consideration. And if they pay for this, they don't pay for that. And a Minister of Health is in that position of making that decision, even within the health sector, about a trade-off. But that's their problem. Not the correct way to do it is still the correct way to do it, to maximize the benefit to the patient that you've established a responsibility with. That's who you're there for, and that's what you're doing when you're there, is trying to optimize their chances of not progressing, of going to a point where they cannot infect their partners or their sexual contacts. That's the agreement. That's what you've agreed to do for them, and you've done that with the proper monitoring of them once you've launched them off. But you could see them. You don't even need to see them as a doctor. You can have the person come and get blood at their convenience every 6 months and get the shot without a doctor visit. And we'll look at your viral load and see what happens. And the ones that go up will come and get you. I mean, if that is really how it is here. So AIDS clinics in the United States are going down to empty, because utilization is dropping because of this intervention and will stay dropped. Think about it. Think if you're taking any drugs of any kind, if you suddenly had something where you injected it once a month and you never had to take them, you don't go to that facility anymore.
I can think of a few AIDS industry organizations that will find that very threatening.
No, I know.
Okay, so stepping back.
Yeah.
Clinical guidelines, and this is an area where you've pushed back on me in the past, I think very directly, and it's deeply affected me. But the argument has gone, what is the point? This is my argument to you. What is the point of having the best scientific clinical guidelines with the latest medications if there isn't really much chance of those being implemented by countries themselves because of cost restrictions? Wouldn't it make sense to have guidelines that reflect the realpolitik of reduced budgets?
That is what occurs. We don't give them a Cadillac version and then go and tell them you got to buy these drugs. They tried to do that with D4T, okay, but we stopped them from doing that and got tenofovir available to countries so they didn't start a bad drug. But I guess my point is that you need to. I'm sorry. The
quality of the guidelines.
Sorry. Yeah.
Best in science or best in practice.
So this is an old dichotomy, and it has always been a tension for those of us in the treatment arena who were in the 80s, the treatment people who brought treatment to our respective hospitals and communities. It was always the best science told us what combinations we should put in a backbone or in an additional antiretroviral. And that was based on the side effects of the drug, efficacy of the drug, side effects of the drug, and ease of taking the medication over time. And not much else. When you start trying to factor in what a country can cost for, you're giving them an inferior drug because it's cheaper. That may indeed be what they've got to decide to do as a country, but they need to start that discussion from what the science says they should do. And no, you can't afford it, country X. And your country, because you can't afford it, has to go with this less optimal drug. In somebody's consideration, analysis, it's less optimal for the following reasons. You, as the committee that decides what your population gets, needs to know that, own that, and change it as soon as you can. What's the path to change it to the optimal regimen? And that committee should know exactly what those drugs are and what the cost difference is in where they are now and where they need to go. Or they're not doing the due diligence for the patients that they've already assumed responsibility for. So that's why I say that. So it's not helping somebody to give recommendations that are third or fourth tier, the best combination of drugs to minimize viral replication in you today and in 30 days and in 60 and in 90 days. I know what those drugs are. I know which ones optimally put you in the best position not to progress. I want you to know that. And if I can't give you that, let's work on why we can't get those drugs available to you, which is a whole nother discussion on the role of a academic medical center and a physician's responsibility to patients. They have abandoned this part of it. They will let that decision be made and not take issue with the delivery system that's giving their patient an inferior drug. We do it in rich countries and we do it in poor countries the same way. It's wrong.
So we're going to have to come back to this. Come back into...
I'm sorry. I'm not used to sitting so close.
No, I know. We're great friends. No, we are. This level of intimacy is if you could see us, if you're... it's a perfect incentive for those of you who are listening to us on your favorite podcast platform to pop over to YouTube and see us in full Technicolor. Okay. Key populations. Now, first of all, who do we mean by key populations? Well, we mean men who have sex with men, our slightly clunky term for gay men, and men who have sex with other men who don't define themselves as gay. Right. We're talking about sex workers. We're talking about injection drug users. And depending on the setting, we may also be talking about teenage girls and young women. We are talking about people who fall through the safety net. One of the risks of this brave new world is going to be that, regardless of a political view one way or the other, countries just aren't going to have the money to be able to continue the outreach to high-risk populations. And I didn't include trans communities. It's really important to do so.
And I know you did. Here's, to me, it's... the high-risk communities that we're talking about are the conduit through which the virus enters the non-high-risk community. Get that? The high-risk communities that we're talking about, injection drug users, gay men, men who have sex with men, people who revolve in revolving doors in relationship to prisons are these people. The black community in the United States has a revolving door with the black male goes into prison, gets infected, does not think of himself, nor is he viewing himself as a gay man, does not change his orientation to his girlfriend or wife, infects her, she goes to her first prenatal visit, and that's her first seropositivity note. Didn't know she was in a high-risk relationship. That's the scenario in black communities over and over and over again. 54% of new seroconversions are in African American women. So this is a stat we've known since 1993 in the United States. But my point is, if you don't understand that, you don't think that the high-risk group has any special importance for the general populations in movement of the virus through the general population, but it's the conduit through which it occurs. You stop that, and you treat people who are infected and positive on the front end, but you get people in high-risk groups from sneaking in through kind of underground backdoor ways. You stop it, and we see those numbers drop when we close all those holes off.
Yeah.
You know?
And that's an area where there is no difference in opinion between you and me. It's the right thing to do because these populations are at risk.
Yeah.
But it's also the right thing because if you drive the epidemic underground,
That's right.
it will find its way out.
And a doctor should want both of those addressed.
Yeah. So I guess in a future episode, we need to be looking at who we need to be bringing to the table, or let me reframe it, how we support the directors of national AIDS programs, the ministers of health, to get different players to the table, whether it's the business community or whether it's faith-based communities. Because again, particularly in Africa, a really critical provider, particularly of treatment.
Especially rural.
Absolutely. And you and I have both got irons in the fire to help address that. So that's something for listeners and viewers to watch out for in future episodes. I guess it would be great to just get your sense, I suppose, almost sort of spiritually about the moment that we are in, because you've always been an incredibly passionate clinician. You, unlike many leaders in global health, wear your commitment to patients very much on your sleeve. This must be, at a very personal level, a very excruciating time.
It has been. I have been confronted on levels professionally through the kind of public confrontation that the Trump administration has put forward on so many different fronts that have challenged the work that my professional career has been focused on for most of it. And the colleagues that I am with and part of in the global community, speaking for them as well, this is a reverberation to the core, and I take it as such. But I also take the challenge as something that we could not, as a global health community, be better prepared to take this challenge on, hear it, and respond to it. My fear is that a rational response is not reacted to in a rational way, and we need to figure out what the appropriate response is for this irrational stare that we get from the Trump administration in trying to move professionally on an issue that should be of top concern to those who are governing at this point. The baton of governing has been passed. We need to help them govern in the ideal sense, and that's what a transition is all about. But you'd have to have two people on both sides of that, just as the Ukraine, Russian discussion with EU and who's at the table and who isn't at the table and who should be at the table and who wasn't at the table that we just went through this weekend. Those same issues are playing out. But I think the profession needs to own turf in this and not allow a diminished playing field emerge out of this by people being unprofessional and unethical in how they frame the discourse. We need to assert and push it back onto, we're not going to accept a conversation that does not contain the content we need or misrepresents the truth.
So for me, like you, my whole academic and professional life, personal life as well, has been centered around fighting the AIDS epidemic. And on that journey, I've come to understand the critical nature of the decolonialization, the localization agendas. Hey, we don't hear decolonialization much more these days. And also the need for a degree of humility and humbleness that all of us need to bring. And I honestly feel as if tectonic plates are moving from underneath the worldview that I thought we had. And so I want to say that I do something more than just hear your pragmatic optimism. I really pray that is
a hope.
Yeah,
It's a hope.
I mean, I gotta say this. The comment of the vice president over the weekend about you referred to the European countries meeting in London about trying to put a just peace together in Ukraine, and his comment was, this is just a random country that hasn't fought a war in 30 to 40 years. And
Unbelievable.
I mean, besides doing the Brits a favor of putting the Putin's little useful idiots like the far right in their box for the time being, what it indicated was, to me, a really significant difference in worldview. And allies don't talk about their allies like that. And so I think we have to take that very, very seriously. And I raise it now because I think it is relevant to the situation we are in with global solidarity around health. And so I think we have to be doing everything that you're doing to give the administration an opportunity to set out its stall, set out its theory of change. We are all in different capacities public servants, and we'll try and make that work in ways that meet the needs of the people that we serve.
That's right. If there is a way to understand that better, the needs of the people that we serve, this is an opportunity to dig deep in that understanding, challenge the other side of the dialogue in the Trump administration, that this is an important professional relationship with the commitments we've already owned with this population of patients. You've done it with 4 years as president before, whether you know it or not, and you're over the platforms that did it. So it's on you to manage this. And I do think that that long-term relationship that started in 2003 is still what holds us to how we manage this transition. Yeah. And we can still get out of this with a legacy that we can be proud of and that still serves the people that started this journey with us in 2003.
Well, let's leave it there, shall we? I think that's a great place for us to pause. We'll obviously come back to a number of the questions that we discussed in this episode. But Eric, I'm just really grateful to you for very directly, for a global health diplomat, setting out what is really important here. And I think for anyone who feels that it's all over, there's nothing to be done, we just have to walk away, I hope they have understood that that is absolutely not the case.
Not yet. Not yet. Thanks, Ben.
Great. Well, that's it for this episode. In the spirit of self-sufficiency, you will see that I am both producer and director of this show. Our executive producer and director, of course, is Eric Aspera from Newsdoc Media. Thanks to the other Eric Goosby, for being such a fantastic co-host. And finally, a big thanks to you. You know where we are on your favorite podcast platform. Please do visit us on YouTube. We're beginning to get some really good traction there, and it would be lovely if you could like us and encourage your friends and family also to visit us on YouTube. With that, I just wish you a safe week and a happy week, everyone.
Thank you. Good.